Hello, my dear students. Today is your first lection of trauma and orthopedics. Welcome to our Department of Traumatology and Orthopedics of Belarusian State Medical University. What the purpose of the lecture today? The purpose is to open the curtain. Why the theater? Why the scene? Because I think that trauma and orthopedics, it's like a theater of medicine. It's very interesting, majestic world. So today I need to perform an introduction. So I need to open the curtain, little, small, a little bit, but opened the door or the window for our interesting world for you. Let's start. So what is it, traumatology and orthopedics? Traumatology is formed from words trauma, injury, and logos, science. The modern interpretation is the system of scientific knowledge about injuries of musculoskeletal system, about the methods of diagnostic and treatment. What means orthopedy? Derives from Greek words orthos, meaning straight, and pedon, child. The modern interpretation is the system of scientific knowledge about congenital and developed disease of musculoskeletal system, about the methods of diagnostic and treatment. You can see on this slide the Professor Nicolas Henry, the Dean of Medical Department of Paris University. He proposed the emblem of orthopedic. You can see it on the slide. It's a not straight tree, but we can treat it, and this tree become beautiful, straight, and strong. What about the terminology? We need to know some type of injuries. Contusion, what it means? The mechanical damage of tissue or organ without violation of the integrity of the skin. Compression, damage of the organ or tissue caused by pressure from the outside or from neighboring organs and tissue, like a hemipericardium, hemopneumothorax, or syndrome of prolonged compression of the limb. What means wound? Any violation of the integrity of the skin or mucous membranes under the influence of external or internal mechanical impacts. Luxation or dislocation. Complete separation of the articular ends of bones or the violation of their congruence. And fracture. Bone damage with the violation of its integrity. But we have to remember that there is always some degree of soft tissue injury with a fracture. So if we said about the trauma of the musculoskeletal system, we understand that it can involve bone, joint, muscle, ligaments, nerve, vascular, or sometimes involve all these structure. So we will analyze bone. If we said about the trauma of bone, it's always fracture. We will analyze the topic of fracture in detail later. So what about the joint? If we have the fracture, if we have an injury of joint damage, we distinguish dislocation or luxation. It means complete separation of the articular ends of bones, a violation of their congruence. You can see on this slide the luxation or dislocation of the middle phalanx of the finger. We consider subluxation, what it means. incomplete or partial dislocation of a joint or organ. On this X-ray, you can see the subluxation of the phalanx of the first finger. And the third degree of joint injury is the simultaneous combination of fracture and dislocation. You can see on the last X-ray the fracture of basis of the phalanx and subluxation of the base of the phalanx, first finger of the wrist. So we can see if we have the injury of joint, we can distinguish dislocation, subluxation, and fracture dislocation. If we said about the ligaments, the injury of ligaments, you can see 3 degrees of damage. Sprain, when some fibers don't remain stable of the joint. Partial rupture, when some portion of the ligament ruptured, but ligament is still stable. And of course, complete rupture, when joint become unstable because the ligament is complete ruptured. The trauma of muscle. We can see the contusion occur when a direct blow or repeated blow by a blunt object strike part of the body. So crushing underlying muscle fibers and connective tissue without breaking the skin. A contusion can result from falling or jamming the body against a hard surface. Also, we can observe a complete or partial rupture of muscle fibers. So, if we have the degree of injury contusion or partial rupture, is a conservative treatment and it's good result outcomes. If we have the complete rupture, we understand that our patient needs an operation. What about the nerve injury? We can see the 3 degrees of severe of the trauma of nerve. Neuropraxia or conduction block, no axonal loss, focal demyelinization, rapid complete return of sensation or function from 3 to 6 weeks. Axonomesis. What it means? Axonal injury with subsequent degeneration. No disruption of the endoneurial shear. Perineurium or epineurium can be ruptured. Complete recovery may take as long as 1 year. And the most severe trauma of nerve, neurotomesis. Severe disruption of the connective tissue components of the nerve trunk with compromised sensory and functional recovery, which never complete on 100%. What about the traumatology department? What about the orthopedic disorders? We can say, or we can speak about the congenital abnormalities, like a congenital clubfoot, as you can see on the picture, and polydactyly on the right picture. Sometimes we said about the development abnormalities, like a scoliosis, is a degenerative disorder of the vertebral column. Orthopedic infections such as osteomyelitis or periprosthetic infection, inflammatory joint disease, arthritis on this picture, and of course degenerative joint disease, osteoarthritis, you can see on the last picture. Metabolic bone disease, osteoporosis, is a very severe problem of older people. Bone tumors and tumor-like formation, and of course miscellaneous conditions like a tennis elbow, synovitis, tendinitis. It's all orthopedic disorder. So let's talk about the traumatism. What it means, traumatism? Is the totality of traumas occurred in certain groups of population during the definitive time period. Main kinds, industrial or not industrial. In industrial, we can distinguish on the job, agriculture, cultural, building, on transport, military, etc. Not industrial is a trauma in life, in street, road, sport, school, and the other. So if we talk about the traumatism, we need to talk about the trauma or injury. What is it, trauma? The sudden action of different factors of environment, mechanical, thermal, chemical, on tissue, organ, and human organism, which is resulting to the anatomic and physiological changes accompanied with the general reaction of organism. Among all cases of primary disablement and mortality is the traumas take the third place in a world, but in young people, as a cause of death, trauma at the first place. So it's a very important problem for child and young person. What about the kinds of injuries? We need to know a single or isolated. It means or appear in any separated region of part of human body, sorry. Multiply injury occur in two and more separated regions or part of human body. Associated or polytrauma, simultaneous injury of the soft tissue and or bones and inner organs in different cavities. Combined, which cause simultaneous or successive action of mechanical, thermal, chemical, radioactive, and other factors in different combination. If you were injured by a Jedi's word, it would be combined trauma. So you understand that the patient with multiply and polytrauma associated injury, it's a very severe and hard injury for our patients. It's with the poor result, poor outcomes of the treatment, unfortunately. So let's time to talk about fracture in details. We talk about the mechanism of trauma, types of fracture, dislocation, soft tissue injury, bone conduction, condition, joint, and complexity of the fractures. What about the mechanism of injury? There are two mechanisms of injury. High energy traumas are open or closed injury caused by force, missile, traffic injuries, crash or blast injuries, falling from height, affecting the body surface and transferring high amount of kinetic energy, inducing great damage of the tissue. So it's a big kinetic energy with the severe crushing of the bone and soft tissue. Low energy fracture was definite as a result of falling from standing height or less. It's the fracture of elder people, which fallen from their height. What about the type of the fracture? We can see the different type. First type is the fracture of a green stick. Occurs when a bone bends and cracks, instead of breaking completely into separate pieces. So we can see the fracture looks similar to what happens when you try to break a small green branch on a tree. This type of fracture is typical for children, only for children. Older people, young people, middle-aged people never have the green stick fracture, only children. The transverse fracture, what it means? When the bone break that goes straight across the bone, only straight across the bone is a transverse. If the fracture line have some angulation, it will be the not transverse, it will be the oblique fracture. Oblique fracture is the bone break at an angle. If the angle is less than 30 degrees, we call this fracture oblique. If more than 30, the fracture becomes spiral. What means spiral fracture? Also known as torsion fracture. As a type of complete fracture, it occurs due to a rotational or twisting force. So if we have the kinetic torsion of the bone, we can see the long spiral fracture of the long bones. Sometimes we can see the spiral fracture on the short bones of the wrist. The next type will be the comminuted fracture. Is a bone break where the bone shatters into at least 3 pieces or more. Sometimes we can see the many fragments, a lot of fragments on the X-ray. The comminuted fracture is always the high energy trauma, not a low energy trauma. But if the patient have the metabolic disorder like osteoporosis, sometimes we can see the comminuted fracture with the low energy forces. The next type will be the segmental fracture. Is a fracture composed of at least 2 fracture lines that together isolate a segment of bone, usually a portion of the diaphysis of a long bone, as you can see on our X-ray. So let's repeat once again. Type of the fracture: green stick, only for children, and for elder people: transverse, oblique, spiral, comminuted, segmental fracture. Let's talk about the dislocation of the fragments. So if we have the fracture, can be without displacement of the fragments. More often, we observe very slight displacement, like in the middle scheme. We call it satisfactorily. Unfortunately, some of the fracture are characterized by severe displacement of fragments. In these cases, we need to perform a reduction. So we need to treat it by reduction or sometimes operative. What about the bone condition? It's a very interesting question because we have the 2 types of fracture. Traumatic fracture, when we have abnormal excessive force, and bone fracture. But sometimes the force is not normal. It's normal force or low force, but the bone is damaged. Why? Because it's pathological fracture. Is a bone fracture caused by weakness of the bone structure that leads to decrease mechanical resistance to normal mechanical loads. This process is most commonly due to osteoporosis, but may also be due to other pathologies such as cancer, infection, osteomalacia, Paget disease, some congenital disorders of the bone, and of course bone tumors and cysts, sometimes secondary malignant bone tumors and primary malignant bone tumors. So if we have the pathological fracture, we need to understand the primary disease, why this pathological fracture in our patient. The next question about the fracture is joint connection. An intra-articular fracture is a fracture that crosses a joint surface. Such fracture also involves some cartilage damage. Fractures to joint are more complicated to treat and heal than simple fracture, and multiplying bones are involved. So, if we have the intra-articular fracture, we understand that our patient always have some cartilage damage. If he have a cartilage damage, he will have a degenerative osteoarthritis in the future. A fracture that does not extend into the joint is called an extra-articular fracture. The last question is a complexity. What it means, complexity? Complete fracture, bone breaks completely. It's snapped or crushed in two or more pieces. Type of complete fracture include single or simple fracture, in which your bone is broken in one place in two pieces. Comminuted fracture, in which your bone is broken or crushed into three or more pieces. So it's complex fracture. Complicated fracture. Structures surround the fracture are injured. There may be damage the veins, arteries, nerve, or soft tissue defects. If our patient have the injury of veins, arteries, nerve, or soft tissue defects, we said that it's a complicated fracture. If we have only a comminuted or simple fracture without injury of the neurovascular structures, it's a simple or complex fracture. What about the symptoms of the fracture? We can see the relative sign of fracture and absolute sign of fracture. What about the relative sign? Pain, of course. All patients who have the fracture, they feel the pain. Pain increases at the fracture site when imitation axial load. For example, if you're taping on the heel, will sharply increase the pain of a fracture leg. But compression or subluxation of the joint, compression of muscle, subluxation of the joint, they always painful too. What about the swelling? Swelling occurs in the area of damage as a rule, but not immediately. Its sign is relatively little diagnostic information because all trauma always swelling. What about the hematoma? Always appear in the fracture area because we have the damage of bone. However, with a bruise or contusion, or hematoma may also appear when the patient have a contusion of the muscle. So it's a relative sign. The last is a dysfunction of the injury limb. Varying degrees of severity imply the impossibility of loading the damaged part of the body and a significant limitation of mobility. But it's to the relative side, because if the patient have subluxation or luxation or injury of ligaments, he always have a significant limitation of mobility. What about the absolute sign of fracture? If you see these symptoms, you understand that it's a fracture. Unnatural limb position. You understand, if our forearm is angled on the 90 degrees, this is a fracture. Pathological mobility. The limb is mobile in the place where there is no joint. If we have the mobility of the middle third of the forearm, we understand that it is a fracture of both bones of the forearm. Crepitus. Fell by the hand at the fracture site under the skin. So you palpate the fracture site and you can feel the crepitus like under your hand. And what about the bone fragment? Yes, the bone fragment is the last of the absolute sign of fracture. Can be seen in a wound, if we have a wound, or can be seen sometimes under the skin. We can see that, oh, it's deformity of the forearm and the bone fragment under the skin. Let's see some cases. On clinical cases, relative side, such as swelling and hematoma, and absolute side, deformity, you can see the deformation. Unnatural limb position, you can see on the first and the second, and of course bone fragments under the skin on this picture, and bone fragments of the malleolus fracture on this picture. What about the diagnostic of the fracture? X-ray rules of long tubular bones. When you perform the diagnostic, the golden standard is X-ray. You never can be sure that it's a fracture before you perform the X-ray. So what about the golden rulers or golden standard of X-ray? You perform in at least 2 projection with the capture of nearby joints. The rule of 2 projection always it's at its anteroposterior or AP view and lateral view, and always both joint on the X-ray you must see. For some location, use additional projection, such as oblique, 3/4, axial, it's the details. How to describe the X-ray? So let's describe together. The first, we need to describe a location, anatomical location. What is the segment in our X-ray? Like X-ray of clavicle, X-ray of humerus bone, X-ray of ankle joint. The second step must be the describe of location, projection. AP view or lateral view or oblique or axial or the another. Then we need to describe a fracture type and localization of the fracture. So is it intra-articular or is it diaphysis? Is it proximal third of the diaphysis, or the middle third of the diaphysis, or the distal third? And of course, fracture type. Is it a transfer, oblique, spiral, comminuted segmental fracture. The last, we need to describe a displacement. Is it a severe or significantly displaced or without the dislocation of the fragments? What about the fragment displacement? How we describe this sign on the X-ray? First of all, we describe the length. Always, if the patient have the fracture with the displacement by length, it's a shortening. So we write the shortening of the femur bone. Then we describe the width. Our fragments can displace or dislocate medial or the lateral side. Sometimes we can describe the dislocated in front or in back side. Then we need to talk about the angulation. We can see the angulation by varus a valgus deformity, or if we have the displaced angulation in front or back, we said about the anticurvation or recurvation of the femur, of the tibia, of the bone. And the last description is a rotation. Sometimes we can see the rotation of the fragments. So we need to describe if the fragment displayed rotationally. Let's describe together. So what the first? The first is location. What is it? Maybe it's a humerus, or maybe it's a tibial bone. No, of course, you know that it's a femur. So we write X-ray of the right femur. You can see R, right. Yes, so it's X-ray of the right femur. The next, we need to talk about the projection. What is it? AP or not AP? Okay, you can see the patella. You can see the knee joint, and you said that it's a lateral projection. So lateral projection, good. Then we need to describe a fracture type and localization. Where the localization of the fracture? We see the fracture. This is a diaphysis fracture, and I think it's middle third of the diaphysis. We can see many fragments, so the type of fracture will be comminuted fracture of the diaphysis in the middle third. And the last, we need to describe the displacement of the fracture fragments. We can see the displacement. We can see shortening of the bone. We see the displaced to the back. We see the angulation, and also we can see the rotation, because when the patient have the fracture of the long tubular bone, it's always have the rotation displacement of the fragments. That's good. So if we have the diagnosis, we need to, of course, treat the patient. What about the treatment of the patient with fracture? Goals of the fracture treatment is prevent fracture and soft tissue complication. Complication can be the damage of artery, can be the crush syndrome, compartment syndrome, can be the non-union, when we want to regenerate the bone, but our organism can't do it. The second goal of the fracture treatment will be the get fracture to heal in satisfactory position for optimal functional recovery. So we think about the method of treatment. Intra-articular fracture needs accurate 100% reduction and stable fixation. Non-articular fracture of bone require anatomical reduction and stable fixation, but we don't need a 100% reduction. When we have a non-articular fracture of the diaphysis, we need an anatomical reduction of the length and of the width. That's all. Rehabilitate as early as possible by active and passive exercise. And of course, restore patient to optimal functional state. We need to restore patient in 100% of the condition before injury. What about the treatment? Let's talk about treatment. Because the traumatology is a surgical specialty, so we have a conservative and operative treatment methods. Conservative, the most often useful, is the plaster of Paris or fixation by plaster. What about the advantages or disadvantages of this method? Advantages. It can be used individualized for our patients. It is durable if taken proper care. It is disposable. It is partially X-ray translucent, so we can perform the X-ray diagnostic how the fracture is healed. What about the disadvantages? The skin cannot breathe, becomes scaly and itchy. It is heavy and difficult to keep clean and dry for our patients. It's a big problem, really. There can be complications like osteoporosis, pressure sore, muscle wasting, and joint stiffness. You can see on the picture the fracture of both bone of the forearm with the good. You can see the displacement of the fragments. So we choose the conservative treatment by plaster of Paris for this fracture. Sometimes, if we have the displacement of the fracture fragments, patient with the fracture of long bones, tubular bones, we need another method of the treatment. It's a too conservative method, but this method associated with the pin insertion. The method is a maintain reduction or traction. It can be skeletal traction when we insert the pin across the bone, and traction by the loading of the bone, and surface traction when we take a plaster or some another devices like on this picture, and we perform the loading without the pins across the bone. Surface traction is a temporary measure when operative fixation not available for a while. Sometimes we perform it for small children. Skin care be injured if applied for a long period, more than 3 kilograms. So it's not for adult, it's only for children. Neurovascular status should be checked during surface traction period. What about a skeletal traction? Require invasive procedure for longer term traction requiring heavy weights. So it's too difficult for our patient because we need to treat on the skeletal traction. If the patient have the femur bone fracture, we perform skeletal traction for 6 weeks. So he need to lie down on the bed 6 weeks. It's too difficult for patients, and it's a very expensive method because it's too money for this patient. So this is not often a method of treatment of the fracture. If we have the displaced fracture, often we treat it operative because we need an anatomical reduction of the fracture. Operative is an internal fixation. What about the advantage of this method? Restoration of absolute anatomical state. So we can perform the absolute anatomical reduction. Shorter hospital stay. You perform operation, 2-3 days of antibiotic therapy, dressing of the wound, and there are no hospital. Our patient don't need a hospital stay. Enables individuals to return to functional early. So if you stable the fracture, you can become a rehabilitation period 2-3 days after operative. Indications: fracture that need operative fixation. Open fracture, avulsed fracture, complicated fracture, fracture which we couldn't treat conservative. Errantly unstable fracture, prone to redisplacement after reduction. So we perform the reduction, but during 6-7 days later, we perform the X-ray control, and we can see the unstable fracture. Unfortunately, the displays of the fragments. So we need to operate this patient. Pathological fracture, of course. The patient with polytrauma, we need to stable fixation of the fracture. And patient with nursing difficulties, patient with paraplegic, patients with elderly patients, multiply trauma. So we need to fix the fracture because we need to care by this patient. What is the devices for the operative treatment? We use nails. You can see on this scheme. We use plates. There are many various kinds of plates. They are so beautiful. We can see the wires and screw. So this is our devices. This is our I don't know. It's our toys. What about the complication of treatment? It is an infection, non-union, implant failure, and refracture. The methods of osteosynthesis are the kinds of osteosynthesis which you need to know in our trauma practice. There are 3 kinds: periosteal fixation, plate, and screw fixation. Yes, we take plate, lie it on periosteum, and fixate by screw. So it's a stable fixation of the fracture. We have the intramedullary fixator, when we take a nail and perform fixation in intramedullary canal of the bone. And of course, we have the external fixation. External fixation, it's when we take a special apparatus, special device, and perform the fixation on the skin. Yes, external. It's a Elizarov frame. We talk about it later in the second lecture when we will describe and we will talk about the open fracture. And X-fix fixator, you can see it on the scheme. And we talk about X-fix, more details of X-fix in the second lecture. So, ladies and gentlemen, it's a our final slide. It's a final of our lecture. And what I want to say, welcome to trauma and orthopedic world. I think you find very interesting things in our medical theater. Goodbye. Take care.